Hello everyone, this is Zina Tanjum. So in this video we are going to learn about drug interactions. So introduction to drug interactions we are going to deal. So basically a drug interaction means an interaction between two drugs or a drug or by the presence of some other substances. So it's the pharmacological activity of one drug will be altered by the use of some other drugs or by the presence of some other substances. So in this, the drug whose activity is getting affected will be called as the object drug, and the agent which is precipitating its such interaction will be called as precipitant. So example for this I have given digoxin and the antibiotics. So digoxin will be the object drug and the precipitant drug will be the antibiotic. So and these will alter or increase the bioavailability due to the destruction of the microflora, the bacterial flora in the lower intestine. This inactivates the digoxin. So this object drug and the precipitant drug will lead to drug interaction. So next is the factors. So these are the factors which will contribute or which will contribute to the drug interactions, or they may predispose the appearance of interactions. So the factors are the multiple drug therapy, the multiple prescribers. Next is multiple pharmacological effects of drug, multiple diseases or predisposing illness. Next is poor patient compliance. After that, advancing age of patient, then drug related factors. So in that, the first one will be the multiple drug therapy. In this, this multiple drug therapy is very common in chronic as well as in the acute care settings, where the therapy in the patients will be therapy to the patients will be given for those patients who are suffering from hypertension and congestive heart failure. So in this we are including an example where a patient is having hypertension and congestive heart failure. So they will be taking antihypertensive medications as well as digitalis for congestive heart failure. So because of the usage of these two medications, it may lead to the abnormal heart rhythms, the cardiac arrhythmias. So these drugs are interacting and giving rise to a drug interaction, which is in this example it is abnormal heart rhythms. So another use of non-prescription drugs like aspirin with other herbal medications, it will lead to drug interactions. So the possibility for drug interaction in this will be 50% for patients receiving five medications, and 100% for the patients who are receiving 7 drugs or 7 medications. So if a person is taking 5 medication, then the possibility of drug interactions will be 50%, and if he is taking 7 medication, then the possibility of drug interactions will be 100%. Next is the multiple prescribers. It is very common for a patient to be treated by one or more specialists, because it will be in the nature of the patient to go to more than one prescriber, and due to this it will lead to drug interactions, because it is very difficult for a prescriber to be aware of all the medications which are prescribed by other physicians. So in such situations it may lead to drug interactions. For example for this is one doctor is prescribing anxiolytic for a patient while the other is prescribing antihistamine. So because of these anxiolytic and antihistamine, they will be having sedative properties which will eventually leading to excessive depressant effect. Next is the multiple diseases or predisposing illness. In this many patients will be taking several drugs because of more than one disease. They are taking so many medications. So for this we'll be taking an example of a diabetic patient with hypertension. So in this multiple therapies will be given to them, which may result in the drug interactions like the hypoglycemics, the oral hypoglycemics and the beta blockers, which may result in the decreased response of antidiabetic drug, so thus causing the elevation in the blood sugar levels. Next is the advancing age of patient. So in this the increasing tendency of the drug interactions mainly in the elderly patients, which may result in the drug interactions, because advancing age of patient means the pharmacokinetic system of the patient, mainly in the geriatrics, there the liver function will be the activity of the liver function will be somewhat decreased. So due to these factors it may lead to drug interactions. So next is the poor patient compliance. So there here also many times the doctor gives instructions, the whatever the instructions which are given by the doctors, they because of the inadequate instructions, it may lead to poor patient compliance, means the non adherence, or it may be the doctor or the pharmacist, which may lead to confusion. Due to that confusion, the patient won't take any medications, which may eventually lead to underdosing or the overdosing, and thus the drug interaction occurs. Next is the drug related factors. In this it may occur between the drugs that have potent effects or a narrow therapeutic index or a steep dose response curve, like the cytotoxic or the antihypertensive or the hypoglycemic drugs. So these all drugs are having a steep dose response curve or the narrow therapeutic index. Because of these reasons, they may lead to drug interactions. And these were the multiple factors, many factors which leads to drug interaction. So next is the drug interactions. They may either be desirable or undesirable. If they are undesirable, it means that adverse drug interactions are taking place. So mostly these drug interactions will be the undesirable only. Few cases are there which are a desired one, means which may give the beneficial interactions. So example for this is the enhancement activity of penicillin when it is administered with probenecid. So next is the drug interactions, the beneficial drug interactions. So in this will be referred as the rational drug interactions, and the physician will intentionally prescribe 2 or more medications in combination. So the effects for the benefits from these beneficial drug interactions are the therapeutic effect will be increased, it will give a greater margin of safety, and it will increase the potency, and lower toxicity will be seen in this. So ephedrine and aminophylline produce additive effect in asthma, and the sulfamethoxazole and trimethoprim will give the synergistic effect. Next is the adverse drug interaction. In this, the therapeutic effect of prescribed medications will get adversely altered. So this may arise due to the error in prescribing, dispensing, or administering, and even how they are occurring means because of the combination of the medication, this adverse drug interactions will be occurring. These are the some adverse drug interactions. The interacting drugs and the major symptoms: the MAO inhibitors, the tyramine, which will lead to the hypertensive crisis. The hemorrhagic episodes will be taken place when we use warfarin or the phenylbutazone, or if the tolbutamide or phenylbutazone is used in combination form, it will lead to hypoglycemic reactions. So these are some of the adverse drug interactions. Next is the types. Areas, the drug interactions, they are mainly classified into 3 types: the pharmacokinetic drug interactions, the pharmacodynamic drug interactions, the miscellaneous drug interactions. So the pharmacokinetic, it's again dividing into 4 types: absorption, distribution, metabolism, and excretion. Whereas the pharmacodynamic, in this there will be the synergism, antagonism, alteration of electrolyte levels, alteration of the GIT flora, etc. Whereas in the miscellaneous interactions, there will be the drug interactions, the drug food interactions, and the drug hub interactions. So in the pharmacokinetic drug interactions, there will be in the absorption, the alterations in the absorption, it will be including the complexation, or you can say the chylation, the GIPH will get altered, the bacterial flora, it will also get altered. So firstly, we'll be dealing with the complexation or with the chylation. So in these the absorption of some drugs will get markedly decreased by the use of chelating agents like the aluminium, the barium, the calcium, or magnesium, etc. So these products will alter the or you can say directly decreases the absorption rate of medications. Example for this is tetracycline absorption they won't get absorbed in the presence of antacid and even in the presence of the dairy products. Dairy products means the calcium will be present in the dairy products. So because of these reasons, tetracycline won't get absorbed properly. Next is the altered GI tract function. So in this, generally the emptying time of the stomach will varies with the intensities of the gastric motility, and it will also depend on the length of time a drug remains in the intestinal gastric tract. So in this, the total amount of unabsorbed drugs like the digoxin or the tetracyclines that causes the GI epithelium will markedly varies with the GI motility. And if a drug passes faster a drug passes through stomach or intestine, smaller will be the amount of drug absorbed. So like the cathetics, they will increase the GI motility and thus reduces the absorption of any given medication. Next is the gastric pH. Altered gastric pH. In this, the stomach or the intestine, the pH of the stomach and the intestine will be get altered due to the interaction of one of the potent physiochemical changes. So in this, the drug ionization, solubility and stability, when they will affect the rate as well as the extent of absorption. Next is the altered gastrointestinal bowel flora. In this, some medication will alter the normal microorganism population in large intestines, and where these microorganisms generally they play an important role in kinetics and action for some drugs. So due to the use of some medication, they will alter or they will decrease the activity of these microorganisms. Example, the oral anticoagulant, they may cause bleeding if they are administered with vitamin K. So this vitamin K will be synthesizing microflora, this vitamin K synthesizing microflora will be destroyed. Next is the alterations in the protein binding. So in these, certain drugs will be there which are absorbed in the bloodstream, and most of the molecules of these certain drugs will get attached to plasma proteins. So the unbounded form of these drug will pharmacologically it will be inactive form. The bounded one will be the active part of that medication, and the unbounded one will be the inactive part. So these molecules, this inactive part, this free molecule, they will diffuse into the tissue and show the effect. So because of the presence of second medication with the if the second medication is having higher affinity for protein, they will compete for the first drug to bind at the protein side. So this displaces the first drug, producing serious toxicity. And example for this is phenylbutazone replaces warfarin at the binding site, which results in the risk of hemorrhage. Next is alterations in hepatic metabolism. So in hepatic metabolism, it can be done by two methods. Means first one is the induction of hepatic metabolism, and the next one is the inhibition of hepatic metabolism. So induction of hepatic metabolism can be done by when a phenobarbital increases the metabolism of warfarin, and due to the increase in the metabolism of warfarin, and the plasma level of warfarin will get reduced, and it will lead to the decreased anticoagulant effect. So same opposite will be in the inhibition. In place of phenobarbital, we will be using metronidazole. This metronidazole will inhibit the metabolism of warfarin, thus elevating the plasma levels of warfarin and raises the anticoagulant effect. Next is alterations in renal clearance. So in alterations in renal clearance, it can be done by three. It is of three types: increase in the renal blood flow, inhibition of active tubular secretion, alteration in tubular reabsorption. So first one, in increase in renal blood flow, hydrolysin will be there, which will dilate the renal blood vessels, thus causes the increase in the blood flow, and it will lead to the increase in the clearance of the digoxin. Next is inhibition of active tubular secretion. In this, the probenecid it will inhibit the tubular secretion of penicillin, thus increasing the half-life time of penicillin single dose therapy. Next is reabsorption. In reabsorption, antacids will be used. So these antacids will reduce the acid secretion, increases the pH of the urine, and thus reducing the tubular reabsorption of salicylates. So this was the pharmacokinetic interaction. Next we'll be dealing with the pharmacodynamic interactions. So in these pharmacodynamic interactions, these interactions will be occurring at the location of drug action, that is at the receptor level. So these the pharmacodynamic interactions will be antagonistic effect, the synergistic, the alteration of electrolyte levels, alterations of GIT flora. So in this, the first one is antagonistic effect. Here we are using acetylcholine and noradrenaline. So these two are antagonistic in nature. So this acetylcholine will lower the heart rate, while the noradrenaline will show increase in the heart rate. So this adrenaline will dilate the bronchial muscles and histamine will contract it. So it means that they are showing the opposite action. Next is synergistic effect. Synergistic or the additive effect will be seen in the trimethoprim and sulfonamide. So this will lead in the additional antimicrobial action. And another example is alcohol with CNS depressants will lead to increased CNS depression. Means whatever the effect will be there, so and so medication like the A and the B medication will be used together, and this will lead to the additive effect of the medication. Like the alcohol with CNS depressant, they will increase the CNS depressant. So alcohol will be the A drug, CNS depressants will be the B drug. So A plus B is leading to the same action but in the increased amount, like increase and more activity